Okay, so for anyone who doesn't know me, my name is Emily and I am the pharmacist resident for Cook this year. And today I wanted to talk about an STI treatment update. The objectives will be to explain what has changed in the STI treatment guidelines, describe all of the STI treatment guidelines and screening recommendations, and review the Cook STI treatment protocol and where to find it. You'll notice that HIV screening and treatment is left out of this presentation, and that's because I'm planning to do a second presentation on HIV screening recommendations and reviewing pre and post-exposure prophylaxis recommendations. So first, let's start with what has changed. And I'll have a couple of questions throughout to kind of poll and ask for some participation. So Christina, if you can get the first polling question up. The question is, what has changed in STI treatment guidelines? Options are preferred gonorrhea treatment, preferred chlamydia treatment, trichomonas treatment, or syphilis treatment. So we'll give a couple of seconds here to chime in. We can probably close it here. All right, so most people are aware that preferred gonorrhea treatment is what has changed. All right. So yes, the CDC just released updated treatment guidelines for gonococcal infection in December of 2020. But first, let's just go over some background. So Neisseria gonorrhea is the bacteria that causes gonococcal infections, and these have increased 63% since 2014. Complications of this infection can include pelvic inflammatory disease, ectopic pregnancy, infertility, and increased transmission of HIV, but effective treatment can prevent these complications. I also wanted to talk a little bit about some health disparities. So on a national level, there's a 7.7 times higher rate of gonorrhea in Blacks as compared to whites, and the disparity was greatest in the Midwest and Northeast as compared to South and West. There's also a 1.6 time higher rate among Hispanics compared to whites, and that's greatest in the Northeast, that disparity. There is half as much gonorrhea infection in Asians as compared to whites, and that's consistent across all 4 regions of the US. That's specific to gonorrhea infections, but similar disparities exist for each of the STIs that we are talking about today, and that's based on 2018 data. So then to look a little bit more specifically at disparities in Minnesota, based on 2019 data, STI rates are disproportionately high in communities of color. The rates of chlamydia and gonorrhea are highest among Black and Hispanic youth, and the gonorrhea rate is 28 times higher, and the chlamydia rate is 9 times higher among Black youth as compared to white youth, who have the lowest STI of all racial or ethnic groups. Just some more data on rates in Minnesota. In 2019, there were 33,725 cases of chlamydia, gonorrhea, and syphilis as compared to 32,024 cases in 2018. 8,063 of those cases were gonorrhea, and that's a 7% increase. 40% of all the gonorrhea cases occurred among 15 to 24-year-olds, and 3/4 of the cases occurred in the 7-county Twin Cities metro area. And this makes gonorrhea the second most common STI in Minnesota. Now to get even a little bit more specific, sharing some data from Cook, there were 76 positive STI tests in 2020. 17 of these were gonorrhea, and we know that 10 of them received treatment. So now let's move into what the updated gonorrhea treatment recommendations are. So previously, the recommended treatment was a single 250 milligram IM dose of ceftriaxone with a single 1 gram oral dose of azithromycin for treatment of uncomplicated gonococcal infections. This has been updated to be recommended that a single 500 milligram IM dose of ceftriaxone be given to people weighing less than 150 kilograms, or a single 1 gram dose for persons weighing greater or equal to 150 kilograms. And if chlamydial infection has not been ruled out, then those patients should also receive doxycycline 100 milligrams orally twice daily for 7 days. And this is the recommendations right out of the guidelines, which is a lot of text, but is largely repeating what we talked about before. And I just wanted to add that alternative regimens for uncomplicated gonorrhea infections of the cervix, urethra, or rectum, if ceftriaxone is not available or appropriate, gentamicin, 240 milligrams IM as a single dose, plus azithromycin, 2 grams orally as a single dose, or cefixime 800 milligrams orally as a single dose is the recommended treatment. If you're treating with cefixime and chlamydia has not been ruled out, should also co-treat with that doxycycline 100 milligrams orally twice daily for 7 days. And during pregnancy, azithromycin 1 gram as a single dose is the recommended chlamydia treatment. There are no reliable alternative treatments available for pharyngeal gonorrhea. So if patients have a history of a beta-lactam allergy, it's recommended that a thorough assessment of what the reaction actually was is recommended. And then if that reaction truly was anaphylaxis or another severe reaction, then it's suggested that an infectious disease specialist be consulted to come up with an alternative treatment. Now, as far as retesting, so it's a test of cure is unnecessary for persons with uncomplicated urogenital or rectal gonorrhea, but it is recommended for patients with pharyngeal gonorrhea within 7 to 14 days after the initial treatment. However, regardless of what the treatment regimen was, it is recommended that retesting be done, ideally 3 months after treatment, because reinfection within 12 months ranges from 7 to 12%. And that retesting should be done regardless of whether the patient believes their partner received treatment. If that retesting is at 3 months isn't possible, clinicians should try to retest within 12 months of that initial treatment. So now just a little bit of the background for why they made this change. Part of it is related to antimicrobial stewardship and looking at the impact on people's microbiome after use of dual antibiotics. Also looking at the pharmacokinetics, 250 milligrams of ceftriaxone doesn't achieve levels greater than the minimum inhibitory concentration for an extended duration. So it's not achieving sufficient levels to treat the infection for long periods of time. And azithromycin resistance is another reason for the change. The percentage of Neisseria gonorrhea isolates with reduced azithromycin susceptibility has increased more than 7-fold between 2013 and 2018. And they note the importance of continuing to monitor for the emergence of ceftriaxone resistance through surveillance and reporting treatment failures on the part of providers to make sure that these recommended regimens continue to be the most effective. So just to share a little bit more about azithromycin resistance, this chart is showing the percentage of isolates in Neisseria gonorrhea with minimum inhibitory concentrations that are elevated to ceftriaxone, cefixime, and azithromycin, and you can see that increase over time. It's also been demonstrated in other bacteria like Streptococcus pneumoniae and other STIs, such as Mycoplasma genitalium and sexually transmissible enteric pathogens like Shigella and Campylobacter. Evidence is also showing increasing concern for the efficacy of azithromycin in treating chlamydial infections due to resistance. So now our second participation question. You have a patient come in who is a 27-year-old female weighing 59 kilograms with no known drug allergies, and she tests positive for gonorrhea but negative for any other STIs. What would the recommended treatment regimen be for this patient? Options include ceftriaxone 1 gram times 1 dose, cefixime 800 milligrams orally for 1 dose, ceftriaxone 500 milligrams IM for 1 dose, or ceftriaxone 250 milligrams IM plus 1 gram azithromycin orally times 1. If you can open the second poll, Christina, please. All right. We can go ahead and close it again. Yes, correct. So it looks like everyone chose the ceftriaxone 500 milligrams IM for 1 dose, which is correct based on the patient's weight and allergies, and that we have a confirmed that they're negative for chlamydia. All right. So now I want to review screening recommendations. So for chlamydia, it's recommended that all sexually active women less than 25 or greater than 25 if at increased risk, and all pregnant women less than 25 or greater than 25 if at increased risk be screened. And pregnant women should also be retested during 3rd trimester if they are less than 25 or at risk. It's also recommended to be screened for in young men in high prevalence clinical settings, regardless of condom use, and men who have sex with men at least annually and every 3 to 6 months if they are at increased risk, as well as for sexually active individuals with HIV. They should be screened at first evaluation and at least annually thereafter, potentially more frequently depending on behaviors and local epidemiology. Similarly, for gonorrhea, so sexually active women less than 25 years old or greater than 25 at increased risk, and all pregnant women less than 25 or greater than 25 if at increased risk should be screened, as well as MSM at least annually and every 3 to 6 months if at increased risk, and all sexually active HIV positive patients should be screened at first evaluation and at least annually thereafter, more frequently depending on behaviors and local epidemiology again. Now in syphilis, it's recommended that all pregnant women at the first prenatal visit be screened and retested early in the 3rd trimester and at delivery if they're at high risk. Additionally, men who have sex with men at least annually and every 3 to 6 months if at increased risk, and same as before, for patients who are HIV positive, if they are sexually active, they should be screened at first evaluation and at least annually thereafter, with consideration for more frequent screening depending on behaviors and local epidemiology. In trichomonas, women who are receiving care in high prevalence settings, such as STD clinics or correctional facilities, and women who are at a high risk, so including women with multiple sex partners, women who exchange sex for payment with illicit drug use or history of an STD, they should be screened. And for women who are HIV positive, if they are sexually active, then they should be screened at entry to care and at least annually thereafter. With regard to herpes, testing should be considered for women presenting for an STD evaluation, especially if women have multiple sex partners. Evidence doesn't support routine HSV2 serologic testing among asymptomatic pregnant women, but there is a note that it may be useful in identifying pregnant women at risk and guiding counseling regarding the risk for acquiring genital herpes during pregnancy. Men who present for an STD evaluation, especially those with multiple sex partners, should be screened, and it can be considered in men who have sex with men if infection status is unknown with a previously undiagnosed genital tract infection. And again, for persons with HIV, it can be considered if they are at high risk for HIV acquisition or are HIV positive. Okay, so now to review some of the treatment recommendations in expedited partner therapy. Preferred treatment options for chlamydia, the regimen is still azithromycin 1 gram orally once or doxycycline 100 milligrams twice daily for 7 days. For trichomonas, the recommendation is metronidazole 2 grams orally in a single dose or tinidazole 2 grams orally in a single dose. For syphilis, for the treatment of primary, secondary, or early latent with a duration of less than 1 year, they should receive a one-time dose of benzathine penicillin G 2.4 million units intramuscular. For treatment of latent syphilis greater than a year or for latent syphilis of an unknown duration, then the recommendation is for 2.4 million units intramuscular once weekly for 3 weeks. And finally, for the treatment of the first clinical episode of genital herpes, options include acyclovir 400 milligrams orally 3 times a day, or acyclovir 200 milligrams orally 5 times a day, or valacyclovir 1 gram twice a day, or famciclovir 250 milligrams 3 times a day. Regardless of the regimen, the duration would be for 7 to 10 days. So for my next participation question, how would you treat the partner of a patient diagnosed with chlamydia in a situation where the partner is unlikely or unable to seek treatment? Options include doxycycline 100 milligrams twice daily for 7 days, azithromycin 1 gram orally once, cefixime 400 milligrams orally once, or cefixime 400 milligrams once daily for 7 days. If you can open the poll again, please, Christina. All right, we can close it again. Thank you. Yeah, so kind of a split between doxycycline or azithromycin. So the MDH recommendations remain that partners of patients diagnosed with chlamydia should receive azithromycin 1 gram orally once, and partners of patients diagnosed with gonorrhea should receive cefixime 400 milligrams orally once, plus azithromycin 1 gram orally once, and partners of patients diagnosed with chlamydia and gonorrhea will receive the same regimen. And that's because if patients are diagnosed with gonorrhea, you presumptively treat the partner for chlamydia due to a high incidence of chlamydia and gonorrhea co-infection. So what this looks like is you can either dispense the medication directly to the patient for delivery to the partner, or dispense a prescription to the patient who can deliver that to their partner. and who can then present that prescription to a pharmacy of their choice to be filled. That prescription can be written for an unnamed partner, or you can simply leave the name field blank. There are materials for either option in the drug room, and steps are outlined in Appendix C of the STI procedure. So who to treat? If the partners are unable or unlikely to seek timely clinical services, they should receive treatment, and the number of doses should be limited to the number of known sex partners in the previous 60 days. If they report no sex partners in the past 60 days, then it's recommended to just provide one dose or prescription for their most recent partner. Informational materials should accompany the medications, and patients should be counseled to be abstinent until 7 days after they receive treatment and 7 days after their partners have been treated as well. So where to find this? It's protocol 0125 on the Kook intranet. So if you go to the 3 Ps, then look under patient care, the clinical care policy related procedures, you will find the STI treatment protocol. It has been updated to incorporate the most recent guidelines, and it also is just in the process of being reviewed by the nursing team and other teams to make sure that the workflow processes are updated as well, and that any changes that need to be made based on switching to Epic are included as well. It also is accompanied by Appendix A, which provides screening recommendations, Appendix B, which reviews HIV pre-exposure prophylaxis, and Appendix C, which reviews expedited partner therapy procedure. So some future questions regarding azithromycin resistance. It is still the recommended treatment for chlamydia and an option for expedited partner therapy despite emerging resistance. But the publication that was produced regarding the updated gonorrhea treatment recommendations does list a single 800 milligrams cefixime oral dose and doxycycline 100 milligrams twice daily for 7 days if chlamydial infection has not been ruled out. So that is the recommendation in the updated materials from the CDC. MDH has not changed yet. And the CDC has also said that a full update of the remaining STI treatment guidelines will be expected within 2021 here. So I anticipate that we may see changes both in MDH EPT recommendations and with chlamydial treatment in general from the CDC, depending on what they find in terms of azithromycin resistance. All right, so in summary, the CDC's updated gonorrhea treatment recommendation is that patients receive a single 500 milligram intramuscular dose of ceftriaxone for uncomplicated gonorrhea and should receive treatment for co-infection with chlamydia with doxycycline 100 milligram twice daily for 7 days when chlamydial infection has not been excluded. And there are updated STI treatment guidelines from the CDC forthcoming for the other infections. And I would expect that there will be changes due to antibiotic resistance. Here are the references I used for this presentation. And credits for the slide template that I used. So thanks for listening and for coming. I can go over any questions that have come up and try to answer them. Christina, have you?
I don't see any questions in the chat. You can feel free to put them in the question and answer if you have one. Or you can raise your hand if you have a contribution that you'd like to make. I'm not seeing any questions or or any hands raised. So you must have clearly communicated all of the components about STI treatment and the new changes. And then looking forward to the April session that we'll share out an invite for that as well. I think we're good to close out here. Well, thank you so much, Emily. This was really great. Thanks
Thank
for your
you.
time.